Okay, let's crack on. Welcome everyone. It's just past 8, and thank you so much for tuning in. We've got a good turnout so far, and I think clinical consultations is always a really popular topic. Um, I see a lot of familiar names, which is fantastic, and it's so nice to see you guys who keep coming back. For those of you who don't know me, my name is Shoaib. I'm a doctor and I'm the course organizer of BitePACES, and we run a bunch of free webinars as well. I don't want to take up too much of your time as Usmaan, who's our course lead, will be running the show shortly. But just a couple of things from me, and we've seen our community really grow over the last couple of months. We have kind of a few hundred people on our WhatsApp group now. We've been doing these webinars fairly frequently. And it's something we really genuinely enjoy. And we always like to hear your feedback or what sort of topics you'd like covered. So just drop me a message if there's anything, you kind of desperately need help with. Always happy to help. We have our courses, as you know, coming up in Jan and Feb. And I know a lot of you got your exam dates recently. So we've had quite an influx of ticket sales. So what I would say is, if you are interested in coming on the course, please do try and secure your place soon. And I know it's probably quite an anxious time because you've got your exam dates come through. But don't worry, this is the first step in getting closer to passing your exams and just getting done with PACES. And as I said, we're here to help you. But without further ado, I'm going to pass over to Usmaan, who's our course lead, and he's going to be taking you through clinical consultations. So yeah, Usmaan, over to you.
Hello, thank you, Shoaib. I'm just going to share my screen. 1 second.
Just whilst you're setting up, Usmaan, I just forgot to say, for those of you who've signed up for the course, bar the people who've signed up today, you should have received an email with the registration form to fill in. If you haven't received that, you can either directly message me on WhatsApp or you can just email us. But yeah.
Oh, I'm not sure where Shoaib's gone.
Yeah, can you hear me? I'm here.
No, you're very fuzzy, Shoaib.
Okay. I'll leave it. I'll leave it to you. Sorry, I think maybe it's an internet issue.
Fine, okay. So as Shoaib said, I'm Usmaan. I'm the course lead along with him, and I am also a doctor. And we've been doing PACES courses now for a while, and are very keen to get you guys on board with us. Today we're going to be talking about clinical consultations. Just before we start, a quick plug of our courses that are coming up soon. As Shoaib said, most of you will have got your dates by now. And so this is the right time to be thinking about booking a course. We have two options. We have a 1-day intensive course, and then we have 4-day comprehensive courses. Our courses are our courses are pride themselves basically on the fact that we have very small group teaching. We have an excellent array of patients with great signs, and you get a mock exam at the end of the day. And really, I think the other thing just to say is that we are a very friendly bunch. All of our faculty have been screened to make sure that they're not particularly mean. And so, you can join us, ask any questions you want throughout the days. And it really is a good learning environment, conducive to taking in all of the information and not feeling threatened. And we have a discount code, webinar20. So if you sign up soon, you can use the code. We've had excellent reviews, which you can see on Google and Trustpilot. People passing 100% in their exam, lots of 5 stars. And as you all know, we've been running some webinars now, and we run them every diet. And if you haven't already, please join our WhatsApp group, which you can find through this QR code, where you can ask for any advice or help if you have particular questions. And we offer tips and tricks at regular intervals to help you get past the exam. All right, that's enough of that. So, clinical consultations. This is something that people really worry about because it's the only station that assesses every aspect of the mark scheme. And it will happen twice during your exam. There'll be one acute and one less acute scenario. And really the aim or the shift to this from the old Station 5 is to make it feel more realistic and more like you are the medical reg, just seeing a patient in a short period of time. And in that time, you're examining that, you're taking a history, examining them, giving them a plan, answering their questions. And so the switch, it's really switched its focus from the old style, like figure out the spot diagnosis based on whether they're MTP or they're distal or the dips are swollen, to, you know, you figured out this person got rheumatoid arthritis, but actually the question is about some complication of the rheumatoid arthritis or a complication of the drug therapy that they've been taking. So the focus really has shifted. And so if you use any old style resources to revise, they may not have got there yet. And what I would suggest is when you're thinking about this and when you're doing mock scenarios with one another, that you make it so that you think about not just the first step of like, well, what is the spot diagnosis, but think about what are the complications and what are the other things that the patient might present with. Because if they have obviously got rheumatoid hands and they tell you in their past medical history, oh yeah, I have rheumatoid arthritis, then clearly there's not going to be many marks for saying they have rheumatoid arthritis. And the thing about the acute versus less acute, so that's important because you know, you should expect that there'll be a scenario which requires you to admit a patient, whereas the other one may be in an outpatient setting or making a plan with a follow-up in a few days' time. And we'll talk about that more in a bit. And so this is what your task is in all of these stations, in this station, essentially. You have to elicit a clinical history and a relevant physical exam. You don't need to complete the history, it says, before carrying out an examination. And we'll talk about that in a bit. You need to think about probable diagnosis or differential diagnoses, and then tell the patient what that is and what your plan is going to be for investigating them and treating them. And then discuss your assessment and answer any of the patient questions from the patient. So all these three things are expected to be done during the short time that you have in the station. And as a result, you need to really set your timing correctly. And we'll talk about that in a couple of slides' time. And this last bit in brackets, assess the patient's views of their problem and clarify what matters to them most. This is really key because they are trying to make doctors who, you know, think about ICE, essentially, ideas, concerns, and expectations. And so the way that you do that is by asking early what the person's problem is and what they're worried about, and then clarifying that as you go on. And we'll see that as we go through. Generally, the setting for these scenarios will either be in an outpatient clinic, it'll be in medical ambulatory care, at the take, MAU, or doing a ward review of like a surgical patient or a gynae patient, for example. And you may either have to take a history from the patient or from a surrogate, which could be like a relevant relative or a friend. And I think just like a thing just to note is that sometimes if, for example, the patient has the sign which they want you to elicit on examination, but maybe they're not the best person at being able to stick to a script, which is why they've then hired a surrogate. When you're doing all of your talking, you should aim at the surrogate. because that's who's going to ask you the questions and that's who all of the interaction is going to be with. You can say, you can ask the patient if you want to be polite, are you happy for me to talk to this person on your behalf? But the implication from the scenario will be that that's what you're expected to do. And it would be really odd for the patient, aka the person who you examine, to say anything if the rest of the station is with the surrogate. So just, I don't want you to be thrown by that if the first time you see that is in your exam. In our course, we often have surrogates because we want you to be prepared for this eventuality. Also, by the way, if anyone has any questions as we're going along, feel free to type them into the chat and we can address them as we go. Next, timing. So in terms of timing, the most of the marks are going to come from the history. And as a result, that is where you should spend most of your time. So 5 to 8 minutes for your history, then 2 to 4 minutes for the examining, and then you need to leave a good 4 to 5 minutes for discussion. So, in total, you have this like 15-minute time slot before you have to move on to the answer to speaking to the examiner for the viva. And so make sure that you leave 4 to 5 minutes for discussion. And this is where I think it's worth discussing whether you examine as you go along or you take a history and then examine. It really depends on you and what you feel comfortable with. In the sense that some people, if they try to examine whilst they're talking, they just get thrown off and they don't really absorb either part of what they're doing. They neither absorb what the person's saying to them, nor do they absorb what they're finding on examination. And it is quite challenging to do that. I think I struggle with doing that in this kind of setting too, where what the person says matters. So really, I think if you can try and just whittle through the history, and then then it will allow you to be focused in your examination. I think the problem with starting examining too early is that you're not really sure where you're going or what examination you want to do, and then you end up doing too broad an examination and you just waste time there. So, everyone is different and has their own focus. Everyone is different, has their own style, and some people can do it really well examining as they talk, but other people it just becomes a bit of a car crash, and I don't want that for you. So whatever you practice doing it both ways, and then before you go to exam day, have the way you're going to do it and stick to that. Don't try going off piste or doing something new for the first time in your exam, because that's when things go wrong. Amani has asked, will there be any clock to mark the time for us so that we're aware of time? There won't be. Just take your own watch. Yeah, so watch in your belt buckle or pocket watch or whatever, because in this station particularly, the timing is really important. If you don't get to the discussion with the patient, you will essentially fail the station because there's so many marks in that. And obviously time just goes away from you. That's unfortunately what happens in these stations, because you're just having so much fun that time runs away. Now, in terms of history, I'm not going to teach you how to take history. You should all know that by now. But the important things just to stress are, at the beginning, start with an open question. What brings you in today? How can I help you? That whatever. The person, either the patient or the surrogate, whoever you're talking to, has been briefed to not go on and on and on and on. This is not a clinical consultation station. Obviously, you need a clinical communication station even. Obviously, you need to communicate effectively, but the point of this is not to stop them from speaking or use your communication skills. The point of this station is to take a relatively comprehensive history, examine them, be able to answer their questions at the end. So you can ask them an open question. You probably won't have to cut them off. They'll just stop talking within like 30 to 45 seconds, and you will have gained information from that question, from that answer. The other thing that is important is I've put it at the end here, which is ICE. Is there anything particularly you are particularly worried about? Some people really are fine with like doing this ideas, concerns, expectations. Some people really struggle with it. If you struggle with it, then just have like 2 sentences that are in your back pocket that you will use every time. You're going to have a different examiner in each station. They're not going to know that you've used it before. So just have to and use them. Is there anything you're particularly worried about? What is it that concerns you today? What are you expecting from this appointment? Yeah, like those, pick 2 of those 3, and ask one at the beginning and ask one at the end. And that way no one can say that you've not iced them. And also it will help you in terms of addressing the problem when you get to the end and you start talking through the plan. The social history. So I've put that in because if you look at any of the mark schemes for this station, they always have an answer to all of the social history: occupation, smoking, alcohol, rec drugs, whether they are independent, what their travel history is, whether they have pets. Given that it's always in the mark scheme, if you have a pernickety examiner, even if their relevant recent travel is not that relevant, just because it's there, they may say, well, you didn't ask it, and I expected you to ask it. Thus, I would just learn that you need to ask them all of these questions and just rattle them off in your history. It doesn't take long. The answers will be really quick. Do you smoke? Yes or no? How many? And they'll give you the answer. How much alcohol drink? And as I say, exactly the same vein as I was saying earlier, they've not been briefed to go on and on and on. They've been briefed to be brief, essentially. So make sure you ask them all these questions because it will get you the marks. And you don't really need to present as opposed to the history station. You're not going to be expected to present the history in this station. So it doesn't really matter. You ask a question, you're not going to have to like talk it all back again. It's just useful information to have. Hope that's clear for everybody. Then, in terms of examination. So your examination needs to be focused and guided by the history. So you want to keep to your normal order of examination. So you start at the hands, go to the neck, face, chest, blah, blah. But you can skip whatever you like. No one's expecting you to do everything in the examination. It's meant to be focused. It's just meant to be relevant to what the scenario is asking for. So, for example, in a TIA, let's say the history seems like it's a TIA, what would be the expected examinations that you do? You can type them in the chat. So let's try and be a bit more specific than neuro, because you're not going to do a full neuro exam. That would take you like however many minutes, right? 10 minutes, but you don't have, I've said 2 to 4 minutes for your for your examination. Good, I'm getting some good answers here. Wonderful. All right, good. So Kim Shin Ho, please do not try and do fundoscopy in this station because it already takes however long to do fundoscopy. And we're trying to make our lives easy here. And they're not going to expect you to do fundoscopy in a TIA station. Okay? Especially if you have to do all of these other things. The specific things are, so the important things would be pulse, obviously, because you want to make sure they're not in AF. Then you can ask them for blood pressure, but you already have the blood pressure because it will be in the first, in your brief, which you'll see, you always get the obs. Then moving to the neck, carotid bruits, super important. Do they have carotid artery stenosis? That's obviously a big risk factor for TIA. Then heart sounds for murmurs. And then in terms of what do you do in neuro? So I think you guys, between you have got it. You're basically right. So power in all four limbs, just like brief, pull me towards you, push me away, kick, kick. So like you do that. So there, it's a bit compound movement, but it's fine because all you're trying to decide is one side weaker than the other side? But it shouldn't be, right? Because they've had a TIA, you think, when the neurology is resolved. Check the visual fields, as you've said, and then probably do facial expressions will be useful. Those would be the things that I would do in TIA, and that's what would be expected from you. If you were to miss, like if you weren't to do carotid bruits or you weren't to check their pulse for AF, like that you would get marked down on. I think how extensive or non-extensive your neuro exam is kind of probably will vary between what different examiners expect. But in reality, the neuro should be normal now, so it doesn't really matter that much. Good. Then in terms of, in the next slide, we'll have all of the answers, so you can have a look at it. Then in terms of palpitations, if the presentation is palpitations, what would be your what would you expect to examine for particularly? Thyroid, yeah, wonderful. Always thyroid, grand. So thyroid status, pulse, yep. Heart sounds for murmurs, anemia, drop. Yeah. And I think the only other thing that I would suggest would be to check if they make sure they're not fluid overloaded, so they've not decompensated from their whatever arrhythmia they're having. If you think if it ends up being an arrhythmia rather than being thyroid disease. I wouldn't examine for Parkinsonism and palpitations because I would expect there to be signs other than palpitations in a Parkinson station. So tremor, pulse, their heart sounds, whether they're fluid overloaded, and then the thyroid status. Wonderful. Then P, if you thought they had a PE. Yep, good heart failure signs. Pulse, yeah, make sure to see if they're tachycardic or not, because that's going to be the most important thing. You already have the respirate, right? Anyway, calves. So I think this is I think this is an important one. So in PE, right, the person's either going to be short of breath or have or pleuritic sounding chest pain or some combination of that kind of PE thing. So really the things that it's easy for you to just like do loads of examining, obviously, but you want to have a high pickup rate. So you need to examine their chest because their shortness of the breath or pleuritic chest pain could be because of their pneumonia rather than because of a PE. So important to listen to their chest. Whether you percuss them as well as listen, it's kind of up to you. But auscultating is really the main thing. Make sure you auscultate their chest everywhere to see whether they've got pneumonia. The other thing that probably is worth doing is their lymph nodes because you're worried about some kind of malignancy, just cervical lymph nodes. And then obviously the calves are super important. They have or they haven't got a DVT. I think in terms of whether they've got hepatosplenomegaly, I mean, in terms of, it's probably the pickup rate is going to be low. It's going to be weird for them to give you a patient with splenomegaly whose presentation is PE. Same with hepatomegaly. So I wouldn't do it, but I don't think you would lose anything from doing it. Just a bit of time. Then syncope or presyncope. And these are like the most common cases, which is why we're talking through them. Yeah, exactly. So I think this is very similar to TIA. Pulse, lying standing blood pressure, some heart sounds. Yeah, volume status would be sensible, but you can probably gain that from their pulse, their blood pressure, and maybe capillary refill time, and then a brief neuro again. So again, pretty, that's pretty standard. And hopefully you're seeing these are going to be the general things that you do. And then endocrine. So if someone's got an endocrine problem, so this is like, Addison's. I mean, yeah, thyroid, yeah, postural blood pressure, good. In fluid status. Perfect. So really in this, you want to be looking for, you would do a brief abdo exam because then you'll see if they've got any stree. You can have a look at their abdomen, make sure they've not got some kind of weird um, malignancy, check their lymph nodes in the cervical chain, fluid status, and then thyroid status, basically, is what you're going to be doing in that one. And then the last thing would be if someone's given you, if there's like a rheumatology or a skin problem, derm problem, obviously you're going to like focus on, let's say they have an ulcer, like a leg ulcer, and obviously going to look at that. But is there anything else that you would look more broadly at in those scenarios? Lung basis, that's like in case someone's got an ILD as a result of whatever the inflammatory disease is. Yeah, good. Yeah, so I think so it will really depend on what the problem is, right? Obviously, if someone's got angst then you should do the angst tests. Make sure they've not got AR, listen to their lungs, do your Schrober's sign, etc. If it's something a bit more broad, like, oh, this person has joint pain, for example, then the important places obviously to look would be looking at their hands, their nails. So like a brief hand exam, because most of the inflammatory arthropathies will affect your hands, um, or whatever joint they think is involved. Look at their nails, that's important. And lung bases, I think, is a wise decision if you think that they are truly inflammatory. And yeah, you could think about doing murmurs. Cool, good. So then the next bit. And so I think I think just the thing to say about the examining before we carry on is the examinations in this scenario are not always the most obvious. And sometimes, and if you do this scenario and you don't find anything on examination, don't, you haven't necessarily missed anything. Because sometimes they do have people who've got a normal examination. Because, most people who have a TIA have got a normal exam, they've got paroxysmal AF. You can't really hear their carotid stenosis. Their heart sounds normally are normal. Um, so and same within palpitations, like until you do a 24-hour tape, you often don't figure out what the cause is. So don't be thrown by the fact that someone has a normal exam. The important thing that they want you to elicit in this part of this station is you don't do something that's unsafe. So if somebody has a TIA and you don't listen to their pulse, feel their pulse, and you miss the AF early, like that's obviously bad because then you're increasing their risk of them having an actual stroke. Same within like a PE station, like if you didn't feel their cough, tenderness or swelling, then that would be bad because you would be delaying your time but to treatment, for example. So sometimes it's not that intuitive what you're examining for. And like when somebody has like lethargy, for example, it's easy for you to think, oh, I could just do like a low full examination on this person, but you don't have time to do that. And so just keep it brief. Do things that you think are focused and are relevant to the history. And and then once you've done what you need to do, even if you found nothing, just stop. Because the problem with this station is that people keep trying to examine until they find a problem, which they may never find. And then it eats into the discussion, and the discussion is where the marks are. So I just want you to all bear that in mind. That's really important. So if we move on now nicely into discussion. So, the next bit of the scenario is always is tell the patient what's wrong and what's going to happen next, essentially. So you're talking to a patient, you're not talking to the examiner. You need to use layperson language. This is important. So if you think somebody's had a TIA, you can say you can say TIA to them, but that doesn't mean anything to them, right? So you could say you've had a mini stroke, means that's relevant in this context. And then you would explain it in more detail in layperson language. So all of the common conditions that come up, make sure you know how to explain them to somebody who's not a doctor. Practice on someone who's not a doctor. You must have a relative or a friend, and tell them, explain whatever to them, and see if they understand what you're saying. And if they do, then you've probably done it well. If they don't, then find another friend or you change your approach. And the layperson language also then applies to next steps. So, and I think this is where people find this a bit difficult because they want to explain the renin-aldosterone ratio, that test that they're going to do. But obviously a patient doesn't know what that is. And by saying it, you're just probably going to confuse them. So in reality, what I would do is you would say, this is what I think is wrong. We need to do some more investigations to find out if that is the case or if there's something else going on. The next steps will include some basic investigations, such as a urine test, then various blood tests looking at some of the salts in your body, your blood count. And then if you have like a special test and you can explain it in a layperson language, then go ahead. If you can't explain it, then just don't bother saying it. You can say, and then we're going to do some more special tests, whether you need to do a scan or not, and if so, what it's for and why. And then any other like weird tests that you may or may not decide to do. And then you need to tell them this is what the treatment options are. If this is right, if this is what is wrong with you, then this is how we're going to treat you. And if you're not sure of the diagnosis, which is, possible, it happens. It happened to me in one of my cases. You just discuss the treatment option of the most likely thing that you think is wrong. And the reason for doing this is you then that way you give them an opportunity to ask any questions that they may have written down. And you always ask them at least twice, do they have any questions? Is there anything else you want to clarify? Is that all clear? You can ask them to repeat stuff back if you want them to, confirm that they understand. But what's more important is they will come with 4 or 5 questions written down in the scenario for them. And so they need to be able to ask those questions because otherwise you won't get a chance to answer them, and that will obviously be a pain. And then just to say at this point, things that they often ask questions about are things that are not medical. Can I drive? If not, how long can I not drive for? What's going to happen with my job? Am I going to be able to look after my wife? Am I going to be able to do X, Y, or Z? Those are generally the questions that they have been briefed in this scenario. And so you need to be aware of like driving rules. You need to be aware of like you can this is going to have an impact on your activities of daily living. This is going to require a hospital admission, etc. And if you don't know it, you can say, I know this is impacted. I just don't know how long for. I will find out and let you know. And there's no harm in doing that, because in reality, like, that's what you would do. And like, you can't know everything, and that's fine. As long as you're sensible, that's the main thing. And I think the other important thing to say at this point is, if you are not admitting the person, or the person is not an inpatient, is making sure that there is a robust kind of follow-up plan. So you say, we are going to do these investigations today. I'm going to book you into ambulatory care in 3 days' time, and then we can go through the results together. Or I am going to discuss you in this MDT, and then I will call you with the results, or whatever. And in the meantime, if you have any questions, please, you can see your GP, or you can contact our specialist nurse on this number, or whatever you want to do. But the important thing is, if you decide you're not admitting someone, or things can happen as an outpatient, or you're seeing them in outpatient clinic, then you give them an appropriate follow-up plan. Because really, ambulatory care is your best friend in this exam. You can say it all the time in any of these stations, because this is all fake anyway. You're not actually seeing this person, so there's no ambulatory care nurse threatening you if you give a slot away. You can say, I will book you into ambulatory care, and I'll see you myself in 3 days' time, and we can talk through what's next. Or I will discuss this with my senior and I'll get back to you, or whatever you want. Like, all of these are really valid options that are completely acceptable, and make it really clear to the examiners that you know how being a med reg works, because that is really what being a med reg is being sensible, making a plan, making a follow-up plan, making sure that things happen. And that's the difference between when you're like an SHO and you're the registrar, is you think further into the distance rather than just like dealing with the problem that's there in front of you. And that's what we want to see. I hope that's clear for everybody. I think this is where people mess up most. Everyone worries about the examining, but in reality, they mess up at this point. If you have any questions, please ask. And in the meantime, I'm going to move on to the Viva bit. So Viva and the QA. So these are generally what they're going to ask you. What did you find on examination? You can say nothing, or tell them what you found, because you won't have said that to them. So they're not, the difference here is that you're not expected to present the whole patient, right? Because they've watched you take the history, examine, talk to the patient. So what they're going to try and elicit is, what have you done? What have you found that you haven't actually told the patient? So what you found in examination, and then what your main and your differential diagnoses are. Because you may have told the patient, this is what I think is wrong, but obviously in your mind you have a differential, and so the examiners want to hear that. They also want to know about if there's any other investigations that you've not explained yet. So like your renin aldosterone ratio, or your 24-hour plasma metrorefrins, or whatever it is that other weird tests you want to do. And they may ask you about your management plan. And then the other thing, sometimes they ask you just to clarify on things that, just to clarify things that you've said to the patient, or the patient has asked you and they don't think that you've answered that well. If they're being particularly friendly, they may ask you, so what is the driving rule, or what do you think about this, like, benefit claim that the person is trying to make, or whatever. And then you can answer it there in a more medical way, where you have to be a bit less nice because you're just talking to the examiner. So that's generally what the Viva will encompass. And then they may ask you something like the Vivas in the other stations, which is, tell us more about whatever pheochromocytoma. But really, that's not the purpose of this Viva. The purpose of this Viva is about what's gone on in the previous 15 minutes, and what have you not told the patient that the examiner wants to find out to get you the marks. And then, the most important slide. What do you do if you're not sure, if you don't know what's going on? This happens. As I say, it happened to me in one of my stations. In one of mine, I think I dropped 1 mark in that station, despite still to this day not knowing what the diagnosis is. So you just need to be sensible. If you don't know what's going on, firstly with the patient, you can tell them there is a wide range of options or wide range of reasons why you may have these symptoms. And until we do more tests, we don't know what they are. These include X, Y, and Z. These are the tests that we're going to do, blah, 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 blah. I think the most likely cause is this. And if it were this, this is how it would be managed. Do you have any questions? Is there anything else I can clarify further? Do you have any other concerns I haven't already addressed? Like that's it, bam, bam, bam. And you'll still use your 4 or 5 minutes in the discussion with them, and they will still have, they have got concerns, regardless of whether you know the diagnosis or not. They will have concerns to tell you, and so you need to ask them for them, because if you don't ask them, they won't tell you. Then in the Viva, if you don't know what's going on, tell them what your positive findings are. Or if you didn't find anything, you can say what you were looking for and why you were looking for it. I thought this person may have had a TIA. I looked for carotid bruits, AF, and a murmur. I didn't find any of these things, but I would need to do further tests to fully rule out their carotid stenosis. And then talk through your differentials on what tests you would answer, and they might help you. They might say, well, this may be like this or whatever, and guide you to the answer. And so listen to where they're pointing you and go from there. And if they do, and on that point, and this applies actually throughout PACES, if they guide you to an answer, like as into a diagnosis, which they could do in your neuro station, they could do in any station, because you've not said it in your differential, they may keep pushing you until you say the right diagnosis. Please then talk about the management of whatever the diagnosis that these people are telling you is, because that's obvious. They want you to get the marks. Everyone says that examiners are mean, blah blah blah. They may be, but equally they do kind of want to pass you, because they know you've revised. And so if they give you the diagnosis, and then you can tell them that the management, they will be happy with that, and hopefully they'll give you the marks. So good. Next, we are going to do 1 mock. So anybody want to be the candidate? And they can talk. One person has the hand up. Whoever that person is can do it. Don't know how I find that. Yeah. Ah, Maya. All right, Maya, you are now allowed to talk. Please unmute.
Yes.
Hello?
Yeah, I'll
All
try.
right. So here's your example. Here's the example.
Yep.
Dear doctor, please review the 64-year-old man who complains of a 1-day history of headache. I found his neurological examination to be grossly normal. Those are his obs. And you are the doctor in ambulatory care. This patient's obviously been sent from the GP. Please assess further. All right. Happy seeing all of that bit?
Yep.
Yeah. So good. Then
So shall I start by taking history then?
yeah. 1 second. So obviously, then this is your task. Just so you are reminded, this is what you're expected to do. So we'll make it a bit shorter, because obviously you're not going to actually examine me, but you're going to tell me how you would examine me when we get to that point. So you can take your history from me. Go for it.
Yeah. Hello. So yeah, my name is Dr. Zol. How may I call you?
Mr. Ahmed.
Hello, Mr. Ahmed. Nice to meet you. How are you doing today?
Oh, it's really bad headache, doctor.
Yeah. I'm so sorry that you're having this headache. And can you tell me more about that?
Yeah, it's just this headache. I've had it for like more than a day now, and it's just really bad.
Yeah, I'm so sorry to hear that. Would you tell me how it begins?
It just started yesterday morning. I think I woke up with it yesterday.
Yeah, and any similar headache before?
No, no.
No. Okay, so may I know where exactly is the pain in the head?
It's kind of all over, but mostly on the right.
On the right side.
Yeah.
So, and the is it in the or near the face or at the back of the head?
It's just all over on the right hand side, really.
Okay. So, is there any injury to your head?
No, I'm not falling over that I can remember.
Okay. And any problem with your vision?
No, my vision seems fine. I mean, I wear glasses, but that's not changed.
So there's no changes in your vision. Okay. So tell me more about the pain of this headache. What is it like?
It's a bad ache.
It's a aching pain. And
Mm.
is there anything that make it better or worse?
No, not that I've found.
Have you been taking any painkillers?
Yeah, I've been taking paracetamol and I've been taking ibuprofen. It hasn't helped really.
As in happy. I'm so sorry to hear that. And would you say that it get worse when you cough or when you sneeze?
No,
How about when you strain on the toilet? Does it get worse?
no,
No. Okay. And do you have any other symptoms along with these headaches,
no, not think so.
like the fever
No, I've not had a fever.
or any stiffness in your neck or
No, my neck's not stiff.
yeah, do you feel like you're bothered by seeing bright lights?
Pardon?
Do you do you feel you are bothered by seeing bright lights?
The bright lights, oh, they're not the best. But I can still stay. I don't need to be in the dark.
Yeah, but you don't like the light, but you don't
No,
have to be in the light.
yeah,
And do
exactly.
you think that noises, if you hear some noises, that does the headache get worse?
No, no, not really.
Yeah. Okay. And the any a a runny nose or uh, anything like that recently?
Mm, uh, well, no, I mean, I've had a cold, but I mean, everyone's got a cold at the moment.
Everyone is getting cold at the moment.
Mm,
Any problem with your hearing?
nope,
Any discharge from your ear or
nope,
any sore throat?
nope,
Any lump bumps around the neck?
nope,
Any coughing or anything like that?
nope,
Any problem with your breathing? Any chest pain?
nope,
Any skin rashes or any joint pains?
nope,
Any problem with your bowels or the uh, your water works?
nope.
Okay, and any weakness or your any changes in sensation in any part of your body?
No, I mean, no, my sensation's been fine. I think it's been like I've been struggling a bit, just like, getting out of bed, but I don't know whether that's just a headache or what.
Oh yes, so you were struggling to get out of the bed.
Mm.
Uh, so when did that happen?
Just the last few days as well.
Last few days. So would you say that this happened because your legs are weak or your arms are weak?
My legs aren't weak. I don't think anything's weak. No.
Do you just think that you are more clumsy than you normally are? You usually are?
No, I'm not. I'm not clumsy. I mean, I've been quite tired, and I think it's also just been a bit of a struggle just to get out of bed. But once I'm out of bed, I think it's been okay.
Yeah. Okay. And do you have any fever?
No.
Any changes in your body weight or appetite recently?
No.
Yeah. Okay. So can I ask you a general question about your your, your some question about your general health? Do you have any medical condition?
I got high blood pressure.
high blood pressure. And would you say it's well controlled? Are you taking medication for it?
Yeah, I take amlodipine.
I'm not the pain. So that's the only medication you are taking at the moment.
Yeah,
Are you taking anything over the counter?
just the paracetamol and ibuprofen that I've talked about already.
Okay. Anyone, any family, any medical condition running in your family?
Nope,
Someone with bleeds in their brains or someone with problem with their kidneys?
no.
No.
That's worrying though, that you said that. But no.
No. Okay. And may I know if you smoke or drink any alcohol?
I don't smoke. I occasionally drink alcohol once a week.
Although unlikely, let me ask if you use any recreational drugs.
No, no, not anymore.
No, animal. So when was the last time you used it? Years ago, as a
40 years ago.
years ago. Okay. So may I know who do you live with?
I live on my own.
Yeah. Okay. So with this headache going on, how are you doing at home?
Um, it's been okay. It's only not been that long. I mean, I don't think I could cope with for that much longer, but at the moment it's been fine.
Yeah, you're doing fine. Have you been eating and drinking fine recently?
Yeah.
Yeah. Can I ask you some more specific question? When you eat when do you feel like any pain in your jaws or anything like that?
I've not really thought about it. I don't think so.
You don't think so? So so uh, yeah, I forgot to ask you earlier, where would you put this headache on a scale of 1 to 10? 1 being very bad and
Mm,
1 being fine, very mild, and 10 being very bad.
9. It's the
9
worst
out
headache I've ever had.
now 9 out of 10. And may I know if when it starts, what were you doing?
I just woke up with it.
Just woke up. Okay.
Yes. All right. I'm going to stop you because that's 7 minutes 30 and that's enough time. So now everybody else, everyone obviously was listening. Type in the chat box what examinations you want to do and why.
So, but I'm told that neurological examination has been completed and normal. Is it?
Exactly. You are told that. You're right.
But I would assume that fundoscoping has not been done. So, and if that's not done yet, I would do that.
Mayo, why do you want to do fundoscopy? It takes ages. They're not going to be dilated. You're not going to see anything. We only have 2 minutes.
Or two, we only have 2 minutes.
Yeah, because it's you've used 7.5 and you've got 15, you've got
So
five,
I
you need
will
5
do
minutes
a
to answer my question.
quick neurological examination. I will check things like look for things like facial asymmetry, and I will check for the visual field, and I will check the. Actually, I've been talking to the patient, so I can see that there is no evidence of dysarthria, and I will also do the quick motor examination and look for the try to elicit the pronator drift, and then I would also do check the neck stiffness for the neck stiffness and the neck stiffness,
Okay,
and yeah, and so yeah, that's and I will feel around the eyes, so especially on the side where there is pain.
okay.
So
All right,
anything
Maya,
that's
good. Thank you. I'm going to mute now for 1 minute. Good. So we've had a history. You have given me lots of options in terms of what we're going to examine. So temporal arteries, as Maya just said, and also as Catherine has written, important because it's a 64-year-old man with the worst headache of their life, which is an ache. We didn't elicit that it was, thunderclap. So although Sabarac is definitely in your differential, important, more likely is probably migraine. But again, it would be weird in a 61-year-old to develop migraine for the first time. But GCA is important, especially because you have this thing of difficulty getting out of bed. So temporal artery is important. Pupils and visual fields. So I know you mentioned fundoscopy, Mayo, but really actually the thing that would be useful is just checking their pupils because that will give you whether they've got light aversion and also just useful for pupils. Then for glaucoma, for example, fields are important. Meningism, so quick neck stiffness assessment. You don't need to do full-on Koenigs. You can just move their head from side to side. If they've got meningism, you'll be able to tell, make them touch their neck, their chin on their chest. And then the last thing would be about, if you think it's GCA, the thing that you're worried about is PMR. And this is important because your question, Maya, that you asked me was, did you have any weakness? In PMR, you don't really get weakness, you get stiffness, which are different things. And so you need to see whether they have stiffness when they raise their arms, for example. So that would be a useful test to do here. And then do we have any, so that those are your examinations. And I'm going to tell you that, you know, the most likely, let's say the most likely cause is GCA, for example. So who would like to answer some questions from the patient? Don't all rush. Anyone? Ah, Bavik. All right. You can unmute.
Hi.
Hello. All right. So please tell me what's going on, doctor.
Hi. So I think from your history and examination, it looks like you might have a bit of an inflammatory disease. So this is potentially causing your headache, and it might be causing the stiffness that you've been experiencing through your arms and legs. I think we need to do a few more tests, though, to make sure that that's the case. To do that, I think the first thing we're going to need to do is check your bloods. Just to see if there's any infection markers. We can look for a specific test that might indicate that this is indeed the case as well. And if this is raised, we may need to do further tests.
Like what?
So did you have pain in the sides of your head, in the
When
temples?
you pressed my head, yeah, it really hurt.
Yeah. So if the particular blood test I'm thinking of is quite raised, we might want to get a biopsy of this area around the temples, and it might show that in the vessels there's some inflammation, and that will give us the diagnosis of this. Have you had any eye issues, vision changes? I believe you said no.
I have not, but that is actually one of my worries because I think I had a friend who had a really bad headache and then they went blind. Am I going to go blind, doctor?
So with this disease, that can be a potential side effect. It can, or complication, it can affect the eyes because it causes inflammation to the vessels that supply the eyes. So that is a potential, and that's why we really want to look at this in a bit more depth and a bit faster. And potentially, I think if this blood test comes back high, we probably need to start you on some steroids to try and reduce this inflammation early.
How long is that going to take?
So
how long would it take for that test to come back?
for the test to come back,
Yeah.
it should be done within the next few hours, really.
Oh, all right, that's good. Can I drive?
As long as you have no vision issues, there shouldn't be any other reason to stop you from driving at this time. I should be quite happy with that.
Okay, that's good. And in terms of this treatment, so you said I need some steroids. That's how long will I need them for? And is there any side effects of that?
So usually with the steroids, we start you on a high dose and we bring them down quite slowly. But we'll try not to put you on them for a particularly long time. In the short term, high doses of steroids can make you feel quite hyper. So we'll ask you to take your steroids in the morning. The other thing that they can do sometimes is they can cause a bit of confusion. And I just want you to keep an eye on that. Do you have anyone at home with you?
No, I live on my own.
You live on your own. Okay. It's very unlikely to be a side effect, but it is one that we sometimes on occasion see. If you do feel unwell, what I'd like you to do is probably contact your GP. And if you can't contact your GP, you can talk to an out of hours. Worst case scenario, if there is nobody that can see you or advise, would come to A&E. The other thing I could do is give you a little checkup tomorrow morning and give you a call just to see how you're doing.
Okay. All right. Okay. Thank you. All right. Good. Wonderful. Okay. I'm going to mute you as well. Excellent. Thank you, Bavik. So good. And then we can talk about the Viva in a second. In terms of, so going forward, history-wise, so that was a good history, Mayo. I think the things that you could do better, and I think for everyone, just to stress, is the concerns and the ideas and expectations are so important in this. So you need to ask at early, what are you worried about? What do you think's going on? What can I help you with today? That's really, really important. So please say that, because that's what will get you marks. In terms of your history. So I think obviously I've just put you on the spot and you're at the beginning of your revision point. So that, you know, if it's like a headache or anything like pain, just do it really methodically. Socrates the pain or whatever the symptom is, and then make sure you just go through the red flags that are associated with that symptom. And then that way it's really clear to the examiner that you've gone through all the red flags in order and you've not missed something that's worrying. If you think that it might be GCA, for example, in this scenario, then you have to ask really specifically about PMR. Is there any pain or stiffness in your joints? Have you noticed any movements are more difficult than normal? That's really key, because that will help you with your diagnosis. Then the rest of the history you did well, and you asked me the relevant questions, but it did take you quite some time. Like I cut you off at 7.5 minutes, and I think you may have talked for a bit longer, which is fine. It's that 8 minutes, but I think probably of the 8 minutes, you probably could have cut out 2 minutes of it and still got the same level of information. So this is just about being slick and asking the right questions to get to the answer. And sometimes you have to ask specific questions. Does it feel like someone hit you on the back of the head? Do your temples pulsate, or are they painful? The jaw claudication question was really important, and you asked that at the end. So you just need to learn that for headache. These are my differentials, and these are the questions I'm going to ask. And you can do that for every symptom. You know, in medicine, there's not that many symptoms that come up. So that's for the history. So that was good. Otherwise, you guys were basically got the important things in the examination. And the fact that you know the neuro exam is normal is always obviously reassuring already. So you don't need to like labor the neuro exam when you're doing it. The important things are going to be meningism, temporal artery feeling, fields, pupils. If you think they have PMR. Then in terms of the answers to the questions, Navik, so that was good. I would say you can say the diagnosis. You can say I think it's something that's caused by inflammation and it's called this, because then it tells the examiner you know what it is, and you never know, the patient may have had like a relative with it or something. So it's worth saying. There's no harm in saying it. And I think the other thing that you need to say here is if you've got this stiffness problem, you can say that may also be the cause of your stiffness in your joints, because we know it's often associated with something else called PMR or with another problem which may cause stiffness in some of your joints. And I think you were trying to make it as layperson as possible, which I appreciated, but then I think you then got a bit lost, because you could have made it, because you were like, oh, how much information am I giving this person? Should I give them less or should I give them more? I can unmute you if you want to rebut me. But I think that was I think that's I think that's just something just to it's about finding the balance. Then what's going to happen to my vision? Am I going to go blind? I think you are correct. Your answer was factually correct. However, it's probably not what the person wants to hear. So you can definitely say, yes, this can cause visual loss. However, we are going to treat you today so that we stop that from happening. I think was the line that you missed. And then the other bits were important. And then obviously steroids. So steroids have so many side effects that you all know. And if you don't know, you need to learn. And most patients know that steroids are bad for them. So you can say steroids are important and the mainstay of treatment, and we know they have side effects. We're going to give you some other treatments to mitigate those, like for example, PPI to stop you from having a stomach ulcer. And these are the things that you need to look out for and we will monitor you as time goes on. The other thing that I think is worth saying is, if this is this, we will refer you to the specialist rheumatologist, for example, because that's, I think, a useful thing to say, and it shows that you know the pathway of this disease. But if you hadn't have said it, then in the Viva, the question, you could have said it, or they would have been asked. Is that okay? Perfect. So, and like these are obviously the these would be the question, the things that you would be expected to know about temporal or GCA in this. Good, perfect. So that hopefully gives you an idea of what you would do. Again, so in that, there's not that much examination that you need to do. The examination would be like 2 minutes. The history is where all the marks are. So you need to make sure you take a good targeted history. And the discussion is where it's easy to fumble. But with practice, you can like nail it and do it in a good way. Perfect. And then I'm going to skip over that. The only other thing to say is we always say that, you know, it's useful to just have 3 differentials for everything that may come up, because that way at least you have something to say. You're never caught dead, and you can always just go back to your 3 differentials. And if you are asked any questions, just try to answer them as directly and succinctly as possible. So I hope that was a whistle-stop tour of top tips and tricks in the clinical consultation skills. Practice is going to make perfect. So practice as much as you can with your colleagues. But I think that the purpose of this session is that so you have structure and you understand this is where marks are gained and this is where people fall over, so that you don't make those mistakes. And I hope that that has been made apparent to you all. Thank you all for watching. If you have any questions, I'll stay on the chat for a few minutes. Otherwise, goodbye, and don't forget to buy your tickets to the course.